So welcome back. For those of you who weren't here for the opening session this morning, my name is Jeff Taylor, and I am the director of the HIV and Aging Research Project here in Palm Springs. So we have a few fans in the audience. That's good. We'll talk more later about what that is and go into some detail about how that came about. But I want to tell you what this weekend has been about. And first and foremost, today is the Reunion Project. And what that is a day-long summit by and for long-term providers. We realize as people get older with HIV, they tend to get more isolated. HIV, especially in older people, is less of an issue as we've had the luxury of doing well on meds for the most part, and the focus has shifted to PrEP and prevention of transmission through becoming undetectable, which are very good things. I mean, we could, if we had the political will and money, we could end the epidemic today just with those two things, and we know that's not happening. But at the same time, those of us who lived through the epidemic for the last 20, 30 years are getting older and facing a unique set of challenges, and that's why we want to bring people together so they can address those, both the psychosocial issues that are come up as well as the medical issues. So this afternoon, we're going to have a presentation from the National Roundtable, and this arose out of the Reunion Project. And the Reunion Project started about 3 years ago with a group of people from TPAN, Test Positive Aware Network, Matt Sharp in San Francisco, Jeff Berry at TPAN, Greg Casson from San Francisco, and myself here in Palm Springs, and decided to start doing these reunion projects and bringing people together. We did the first one with TPAN in Chicago, and the second one was right here in Palm Springs in November of 2015. And we've since gotten more funding, and we've been doing these around the country in places like Atlanta, Fort Lauderdale, Seattle, DC is next up later this year. So it's Philadelphia. I'm sorry, Wahida. Philadelphia has done it twice. So Philadelphia has the distinction of being one of the first, and they've also done it a second time, and now we've done it as well because there's such enormous response in the community that people say we want to do this again. It shouldn't be a one-off event. So that's what we've done here today. And let's start with the roundtable people, and they can tell you about how that came about and what they came up with over the course of the last day and a half. So thank you. And you can move around the stage if you want to.
Well,
You just want to sit there or whatever works for you.
Is it all right if we sit here?
Yeah, let me get you the...
Is that right? Sure. Hi, everybody. Look at my people. That's what I'm talking about. Hi, my name is Wahida Shabazz L. I'm from Philadelphia. I come to this work as a woman living with HIV, diagnosed in 2003. And I've been with the Reunion Project for the last couple of years. I came onto the steering committee to create more diversity, to make sure that we're building a community that's inclusive of women and people of color and short people and, all that kind of stuff, right? Yay! Yeah. So I get the opportunity to just tell you a little bit about the 2 days we've been here. We've been here for a couple days. We had a full day yesterday. We called the round table because we're talking about what our lives are going to look like right now that we've survived, right? I survived the diagnosis. I mean, that's one of the biggest things I've ever done. But many of us, we've learned that many of us have survived a lot of stuff even before HIV. That's one thing we talked about in the room. We weren't able to really come to this one definition, what is a long-term survivor of HIV, when many of us survived homelessness and poverty and racism and transphobia and homophobia. We've survived all that before HIV even came along. So we are long-term survivors of a lot of things. And what the Reunion Project does is create a bridge where we bridge smaller communities into larger communities. And that's one of the hopes that we have going forward. One of the four hopes that we have going forward is that we continue to build that base and build the smaller communities into larger communities. So just to give you a little background about how we got started, with the roundtable, we selected the Reunion Project selected a selection committee. We call it the PIC, participant invitation committee. And these people were about 5 or 6 people. They were charged with inviting about 4 people each from their communities, who would be good, who would bring their brilliance. We talk about bringing our brilliance and our brokenness, right? I learned that in there yesterday too, right? That we're broken and we're brilliant, but we knew that we would select 5 people who would bring people in who would be a part of this conversation. And we wanted to have 35 people. We ended up with about 50 people because even after they made their selections, we saw there were some communities that were missing. And so we invited a few other folks in. We ended up having about 50 people, wonderful, wonderful people, all brilliant. I'm not going to say they're broken. I'm talking from, right, but they were all brilliant and they were all very engaged the entire time. And so after going through exercises, and we had two phenomenal facilitators, Vanessa Johnson. Happy birthday, Vanessa! That was her cake that y'all was eating in the cafeteria. And also Mike Shriver. Is Mike still here? Okay, great. So we had 2 facilitators who would facilitate the process, and so we all worked really hard. And I'm going to stop there and let Dave pick up about some of the things that. You want to talk about some of the things that came out of it?
Sure. I'm gonna ask for your help with that.
Sure.
Just so you know a little bit about me, I'm not living with HIV, but 31 years ago when I was 19, 2 weeks into coming out, got my very first boyfriend. He was 23, and he told me that he'd been diagnosed with HIV, and he had been in the hospital with PCP pneumonia, and he was only 23 years old. And I didn't see faces like ours in the posters and in the kinds of social media, or not social media, we didn't have it, in the kinds of things that were out there. And so I joined ACT UP, actually, intending to focus on youth issues. But I also started volunteering on a hotline at an organization called Project Inform. And I was too high on pot when I was in sophomore year to get through biology without a D-. So needless to say, and I was an artist, so I never expected to have anything to do with science and medicine, but having to give out whatever information we had in 1989 and 1990, which was essentially nothing, and it was all herbs and it was all alternative, we did our best. And so here we are 31 years later, and my job today is talking a little bit about the science and the research that we feel like is needed to help people who have been living a long time with HIV. So should we start there?
Yeah, I just want to say one thing before we start, because the feeling that I'm having coming out of that day and a half meeting that we had is that I do believe that we will win.
Yeah.
Does anybody believe we'll win? I do believe that we will win, and so I just want to so we have 4 buckets, right?
Yeah.
He came out with 4 buckets after some amazing facilitation and synthesis of information that we had all talked about. And one of the things that we agreed to do, that we agreed to collect data on people living with HIV, ages, places where we live, long-time survivors, and let me say this: long-time survivor, we learned it didn't mean that you had to be over 50 or over 60, right? We had people in the room who had contracted HIV through birth, right? So, and I know for some of us, if the day of my diagnosis, that was a pretty damn long day. I mean, the way I remember it, that was one of the longest days of my lives, right? So it's self-identified who long-term survivors are. But we committed to collecting data, the data that's around, and we also committed to doing some of our own research to make sure we can collect the data that we need to document that we are still here. They thought we wouldn't be here.
So, let me go up here so I can see. So we don't think this is the definitive list because the room was small. There were 50 of us. There are, thousands upon thousands upon thousands, so there's more experience that can be, brought to bear. And that's part of the next step is to get that experience and that wisdom so that we can build a movement. But in terms of the research, what we tried to do is reach some consensus on where there were gaps. And one of the real gaps was disparity, across communities, about communities, In terms of the people who have participated in research on people who are living with HIV for a long time, a lack of women of color, a lack of people with trans experience, a lack of people who either acquired HIV at birth or as children, who are now in their 20s and 30s. So that's one of the gaps. Also, having the community be a part of the research rather than the subjects of research was a really, really important thing. We've been doing that for 30 years, and there's a lot of wisdom and a lot of ability to do that. And we need to make sure that whatever research happens is informed by and shaped by people living with HIV. One of the problems that was outlined was the fact that when a research study gets finished, it can take years upon years to actually get to the point where anybody knows about it and starts putting it into practice. And that was something that we talked about, was the desperate need. We don't have time to wait for the data to start informing programs. So there were some researchers in the room, and they said, come talk to us. We will talk to you. Come talk to us. Let's get moving. The other thing that I spoke afterwards to someone, and what she was saying is, she said, I'm sick of hearing about the need for more research. Number one, about certain things, because some research has been done. And hasn't been put to bear. But then the other thing she said is, sometimes we just need to do shit and get started and then measure it. So I think that's a legit thing. And then the other part of it is that if community is going to be involved, community needs to be fully supported. And sometimes that means financial compensation to be able to take the time away. I mean, certainly a lot of the people who are treatment activists and research activists, for a long, long time, we depended on them to give it away for free. And part of the reason is the way that our disability structure happens in the United States, which is that you're not allowed to earn any money beyond what you're being given, the small stipends that we would sometimes be given out. So that was something that was noted. Also, the practicality. We needed research that would be about the lived experiences and the lives of communities, regardless of the denominator. So again, looking in this case about what were some of the conditions that people had that were related to age, perhaps more than HIV, related to HIV more than age, and how those things kind of come together. Some of that research is out there, but there's lots more to be done, in particular about women, cis women and trans men. That hasn't been done. And then standout issues that came out in terms of some of the research. And research is not just the medicine, it's the psychosocial. Huge need. Social isolation. Some of one of the things that came out of New York HIV and aging group was a sense by so many there that folks have been forgotten and put aside, and that has really profound impact on people, and so that kind of stuff needs to be incorporated. But the standout issues from the research part were dealing with the South of the United States, where the epidemic is raging and has been raging for some time, and where resources are so poor. Women, long-term impact of therapies. So even if the therapies the antiviral therapies we have now are a little kindler and gentler, the ones we did have weren't. And we just don't know the long-term impacts of what it means to be alive today, but have taken those medicines for a long time in the past, and what lasting impacts they may have had. Trauma, as Wahida was saying, a lot of the things that some of us experienced in childhood, continue to resound and affect us. And so rates of challenges with mental illness and other kinds of things were already present in the communities that we come from before HIV even happened or became a central part of our lives, however we were affected. And we talked about rapid dissemination. So do you want to talk about programs, Wahida? Because, let's see.
Yeah. So one of the themes that went across, we talked about research, programming, community engagement, and we talked about advocacy. One of the things that went across all of those categories was economic justice. right? And I know you touched on that as economic justice, and that's, not being perpetual volunteers. Yeah, right. And also for people to be able to accept, even we talked about research, we talked about people who were afraid to take the stipend because they were afraid. I'm going to do this research study. I'm not going to take the stipend because it's going to impact my ability to keep my health care, right, or my benefits. So one of the things about community, we do that everything that we were talking about, research, community, programming, all came down to advocacy. These were the things we would advocate for. And what I said that I would, bottom line, would be building bases and building bases for power. And what that means is the same way that we put that selection committee together to call these 50 people together for the round table, we're going to keep that selection committee together, and we're going to start collecting information about people who are longtime survivors everywhere. And the reason we're going to do that is because when we want to advocate for programs, when we want to advocate for programs, community needs, community involvement is important. MIPA, meaningful involvement of people with HIV, meaningful involvement of people with AIDS. Nothing about us without us. So anything that's going on in the community, we need to have community engagement for any programs. And so what we're going to do is collect information. I'm going to talk to 10 people. I'm going to tell 10 people about the beauty of being connected to a larger community. We talked about holding each other's hearts, right? And so if a lot of us, we know in our communities live in isolation, all right? So one of the commitments that I made is to support a group of people to pick the selection committee who will continue to reach out. And then when we need to advocate for research, community engagement, for programs, that I could send an email to one person who would promise to talk to 10 other people, and those 10 people would promise to talk to 10 other people, and then we have 100 people to make that call, or 100 people to sign on to that sign-on letter. Hopefully one day we'll be signing on the legislation, right? Right now we're not talking about legislation at this point, but at some point we're going to need legislation to support people who are surviving with HIV, people who are older, right? I know we have the standard of care that says that every 90 days we go get our blood work done, we see the doctor. As a person who's aging with HIV, maybe we need to see him every 60 days because there are other things going on. Right? So at some point, we're trying to develop and build safety nets for ourselves, and also to build our power, right, through base building. So that's another thing that we actually talked about. Another bucket that we talked about was we did a timeline. Right, we did a whole wall, and we did a timeline that was very emotional for a lot of people because we put little dots up, like the year that we first heard about the word AIDS, the year that our diagnosis came, right? The year, maybe in some timelines I've seen the year that you started taking medication, right? It became real. The year that you knew that you wasn't going to die, right? And so there was a timeline with several of these factors, and when you can look at the board, and it came alive that you could see when. You could see when most of us received diagnoses through the timeline, but it was very emotional for a lot of people because it was so personal. And a lot of us didn't know we were coming here like to be that vulnerable, right, in the room. But we decided that we need to tease that timeline out even further than that. We have a commitment to do that, to making it a timeline about long-term survivors. Right, and connecting the trauma that most of us may share, trauma in childhood, and that's something that we can't deny, that there is some trauma related to our HIV, diagnosis. And I'm being very careful with my words because we also made a commitment to use people first language. So I'm being very careful with the words I use because I don't want to say HIV infected. I don't want to say full-blown AIDS. I don't want to say those things because they don't define us, right? So we made a commitment to use people first language, people living with HIV, survivors of HIV. So I'm being very careful with my words because it's something I have to learn. It's something that we have to learn, right? So that we can teach our other communities and teach our providers and people who give us services that this is how we identify. We identify ourselves as people, real people with real needs, and not just the condition that we survived, right?
And just some of the programs that people identified that we need and that didn't exist or don't exist included things like navigation that is truly culturally competent and sensitive and meets people's needs. I think employment, helping people find ways to work and have an income, and that doesn't completely leave them stuck with certain levels of disability income that may not meet their needs and often doesn't. That it needs to be individual and community-based, that it needs to be based on a wellness model, that it needs to be integrated. Too often, we don't have enough geriatricians in the United States anyway. Someone said that there are only 3,000 across the entire United States, and most of them have very little training in HIV and almost none in culturally competent care. And yet, those are the kinds of places that folks find themselves having to receive services as they get older. And on the other side, although I think many are trying and scrambling and racing hard to get this competency, a lot of HIV specialists don't really understand how to manage people who are older and a lot of the conditions that arise as people get older. Something else that people talked about is the difference between access and accessibility. Something that really brought this home for me, I was in New York doing a series of site visits, and someone was talking about services for people who are older in the Bronx. And although the services technically existed, they had no way of getting there. So, that's a problem. Although there were support groups and socials and things like that, people had no way to get there. And so issues of the service might exist, you might build it, but people can't get there. And so that's just one example. And there are other kinds of accessibility issues that need to be addressed. Another one was competence, and it's not just the actual competence to do the job in terms of mental health, social services, medical services. It's the experience from literally the moment you walk into the clinic door until the moment that you leave. And then if you have to go to the pharmacy or whatever, or the person you have to deal with on the dealing with the insurance or any of those kinds of things, that those kinds of things are really, really critical. The thing that just jumped out over and over and over again is mental health. That is a hugely it's just not there for many people. And one of the people brought up an example of, this was in New York City, is that they had this was at dinner. The guy was telling me that he had a friend who was diagnosed with very severe depression, had Medicaid, and got an appointment 3 months later. And so, that's if you're lucky enough to end up with competent mental health care. So that was something that folks from a programmatic level said is in dire, dire need of expansion. As Wahida said, expanding partnerships and stakeholder engagement in some of the economic justice stuff that goes along with the employment work that, Mark was there, Misrak, to talk about the project that he does. I think there's a lot. I would say go up to folks afterwards and see them. Those who are at the policy meeting, can you raise your hands so folks know?
Those were at the round table.
Go talk to those folks because they were there. They can better represent, I think, more fully represent than what Wahida and I are doing right now. And there's a level of expertise and wisdom among those folks that is really deep and important. So, and I guess I would say is walking into it, when I was asked to be a part of the planning committee for the last couple of days, the as I understood it, the goal was to take tally of what the biggest issues were from a policy and advocacy perspective, the things we needed to advocate for, the policies we needed. And I think we got there to some degree, but I think that we also flexed. And Vanessa and Mike, thank you so much for helping us do that, because I think we came out with some of those things, but I think there's also a lot of humility that's got to be done differently by different stakeholders who weren't at the table for this particular meeting, and it needs to be sensitive to the geographic location where these kinds of things are taking place. So,
Yeah, absolutely.
Can I add?
Yeah.
Sure.
That we want to eventually compile this into some sort of document.
Yes.
But it's got to be more complete, and we're not completed. It's not done yet.
Exactly.
So once we get it done, then it'll be something that everybody can look at and use in their communities.
And that thing is a report out of what we've done.
Exactly.
And hopefully, if others do things in their own local areas, making sure that information gets out as well, so that we don't have to reinvent the wheel every time.
Yeah, we're absolutely committed to finishing the report, and the roundtable steering committee will go over the reports, over everything, and then we will finalize it. We won't finalize it. We will complete it to the point where we send it back out to all the people who participated in the roundtable. They will finalize it and approve it, and then it'll be sent out to everybody in the world, right? Who wants to know what we're doing here? You know, what we do in the United States is lots of times is a model for other places and other people. Don't think that what we do does not impact other places. There were people there in our group from other countries, and they talked about the services that we have here and the impact that the service that we have here has in other places. Like I think they talked about they didn't receive medications in a particular country, and I don't know if Solomon is here. Was it Peru?
Yeah.
Yeah. He talked about they didn't receive medications. I think was it 2004?
Yeah.
2004. So that's a long year. And for us, we just assumed that everybody's going to get medication. You're going to get on these meds. You get these protease inhibitors in 1996, but the protease inhibitors didn't get to his country until 2004. So we had a lot of different views. We also talked about the importance of peer advocacy, peer navigators. In some places, they say that's going away. In the place where I live in Philadelphia, it's not going away. We have peer advocacy, peer educators, peer specialists. The therapeutic value of walking in my shoes, right? Most of all of us are here because we're survivors, right? Yes. Wait a minute. Oh.
Example number one. Yeah.
Oh, goodness. I think I'm going to throw this away. No, they tell me time's up. So what I want to... So anyway, no, seriously, no. Now I'm going to say one more thing, seriously. We have to talk about our other bucket of next steps that we're going to do. USCA is coming up, United States Conference on AIDS. That is going to be a time when the roundtable group is going to meet again. We've all been encouraged to submit scholarships over the next week, over the next month, and also to submit abstracts over the next week. So we have a committee who's going to work together to make sure that we actually put an abstract in so that we'll be able to talk about long-time survivors at the United States Conference on AIDS. And so we plan on meeting together and continuing to have these bridges of smaller communities to larger communities. We're just beginning, and I'm so happy that we had an opportunity to not just work together in the other room, but to come out here, right, and begin to sharing with our larger community, right, that we are moving. And that our whole entire existence has been an act of resistance. We're in a time now where all we hear about is resistance. Hashtag resistance. That's been us all along because we weren't supposed to be here. Right? They said we wouldn't last. They said we wouldn't be here. And now we're here as seniors. We're here coming up on seniors. We're here as over 50. We're showing up as young people with 26 years of experience of being a long-time survivor. We are very unique and we're very blessed. Thank you.
Great. Thanks so much, David and Wahida.
Thank you. The remote?
Oh,
There.
it's right there.
Oh.
You're gonna take that with us? No, we're not.
So that's kind of a synopsis. So much happened in that day and a half. You couldn't begin to encapsulate it in the space of half an hour. So thank you for that. And now I want to kind of move into what we're doing locally and what we've been doing. We've been kind of at this for a while. So let me talk about Heart PS. Well, I mean, we talked about this before. 50% of people as of 2015 living with HIV are over 50. By 2020, so that's in less than 2 years, that number is going to be 70%. So if you put that in perspective, there's about 1.2 million people in America in the U.S. living with HIV. So that's over 500,000 people as of now, and that's going to be 700,000 by 2020. So that kind of puts it in perspective. I call it, we're riding on the edge of a wave of a silver tsunami because it's going to crash on us. And the reality is it's already here in Palm Springs. All you have to do is look around the community and you see lots of older gay folks, many of them living with HIV. It's really become a mecca for a lot of reasons. Has anybody here seen the movie Desert Migration? Show of hands. Yeah. If you don't, it's online. It's available streaming. If you haven't had a chance to look at it, a local filmmaker named Daniel Cardone put this together, and there are people in the audience who are in that movie, and it's a really wonderful depiction of the lives of men in San Francisco who've been living with HIV for decades, and what brought them to the desert and the struggles and successes that they've had over their lives. And it's a really good cross-section, and if you haven't had a chance to see it, definitely do, because I think that really encapsulates the experience that we have here in Palm Springs of living with HIV. So, the big question is, we talk about premature aging. Is it accelerated aging? We don't know. We're just getting older with HIV. It's something we never expected to happen. The research community, our doctors, we were told, most of us, when we were infected, you're going to be dead. It was a death sentence, and here we are. The whole thing has been one massive 35-year-long experiment, and I think we need to recognize it as exactly that. We used our bodies as guinea pigs to test the drugs that now keep us alive. Not all of us made it, but we've been actively engaged in this endeavor from the beginning, and we can't stop now. I think we've had kind of a lull. The attention has shifted away, but now as we have this huge kind of bolus of people reaching, older age and experiencing all these different things as a result, both psychosocial and medical, as they were talking about, we need to come together as a community and demand the research, generate the research, and we have the power to do that, and I want to talk about how we're making that happen here. So this is some of the, I'll skip over this. This is just boring medical stuff. We all know this, the heart disease, the cancer, the blah, blah, blah. We're living that, and here's Desert Migration. And here in Coachella Valley, the average age of people is 51.2, and this was as of, I think, 2014. And you compare that to the rest of the valley when you bring in, like the city of Riverside, only 24%. So we're more than double of the rates of older people living with HIV here in our Coachella Valley. So what are we doing about this? So we decided a number of years ago, a group of providers and people living with HIV came together. The providers were frustrated because they wanted to do research. Most HIV research, as you know, if you've lived in other cities, happens at big academic research centers like UCSD, UCLA, UCSF, places like that. We don't have a big university based here in the valley. We've got College of the Desert. We have kind of a satellite campus of UC Riverside, but we don't have that resource here. So there haven't historically been a lot of opportunities for us to even participate in research, let alone generate research right here. So they came together and said, we have a unique set of problems in our population, and there's very little research in older people with HIV. Everything kind of stops at age 50. In fact, a lot of research trials won't let people over the age of 50 even join them, which kind of is crazy given the demographics. But again, this is kind of a historical artifact. People weren't expected to live. They didn't want to confound the research questions with old age problems. But given where we are now, we need to be looking at those confounders and find out what they are and how they affect people with HIV. So we came together and started meeting. At first, it was just a group of 4 doctors and a few activists. They called themselves the Gang of Four. And 4 years later, we have named ourselves. Initially, we called ourselves the Coachella Valley Community Research Initiative. We decided, that's really not specific enough. People don't know what that means. Our name needs to say who we are. So we rebranded ourselves the HIV and Aging Research Project, Palm Springs. And our mission is pretty straightforward: to improve the lives of the large and growing population of long-term HIV and AIDS survivors by studying the impacts of long-term HIV disease and its treatments on the natural aging process. So basically, how to live better. So as I said, we were approached as a community for research by other institutions, but we couldn't do it ourselves, right? We don't have those big academic research institutions to do that. So we decided that we needed to develop that capacity ourselves. We have a lot of stakeholders, and by that we mean not just people living with HIV or their providers, but their caregivers. We have blessed with so many community-based organizations in this community that serve the needs of people with HIV, and they know better than anybody what the frontline needs are that people have. And so we have the stakeholders, but everybody's kind of doing their own thing. And you think, well, why don't the doctors do the research? Well, they've got clinics all day long. They've got sick patients to see. And their clinics are designed to serve the needs of patients, and some of them are designed to make money. And there's just not a lot of room to squeeze research in there, even if they say that's a priority and something they wanted to do. So we decided that we should be the ones to do it. So the question became, how do we engage these stakeholders? And we got a grant from PCORI, and I don't know if people have heard of that. It's called the Patient-Centered Outcomes Research Institute. And that's part of the Obamacare, or the Affordable Care Act. And it's actually designed to help do research that answers the needs of patients and make their care better. It's not just answering theoretical questions dreamed up by somebody in an ivory tower. This is real, on the ground, what's going to make people healthier and make their lives better. So that's what they're focused in. And we were really fortunate, and I don't know exactly how it happened, but when we started this group, we decided we need to do some focus groups, find out what the community needs, and to kind of reinforce what we already knew. That people want to be involved. They don't have the chance to do it here in Palm Springs. Many of them have done it elsewhere, and they moved here, and it's like, why can't we do this here? The researchers, of course, as doctors with busy clinical practices, had their own challenges. So they came across us, I should say. The UC Riverside School of Medicine has something called the Centers for Healthy Communities. And so they're a relatively new medical school, and they started just a few years ago, but they started with a different model. And they decided from the outset, they're going to reach out into their community and partner their doctors and their research with the communities to address their local healthcare needs. And so they came across us and realized that, hey, these people are already doing it. And so they partnered with us, and I work with someone named Brandon Brown, who's going to speak next, who's a socio-behavioral researcher at UCR. And we applied for one of these PCORI grants for capacity building, specifically to, as the name suggests, help us develop the capacity to do research here in the community. And the first step of that is doing a series of reaching out to the stakeholders and finding out what their views are to help that define what the research should be. So we were tasked with putting together stakeholders to conduct the research by creating a shared governance structure that includes all the stakeholders, not just the doctors, not just the patients, but bringing everybody together, disseminating that knowledge and developing the relationships. And that's something that David and Wahida were talking about, is how do you get the knowledge back out there? It's not just stuck in a journal somewhere that other academics read. We need to get back to the providers, back to the patients, so they know, did it work, did it not work, and how can we use it to make people's lives better? And then most importantly, and that's what we're doing right now, is identifying and exploring the key topics for future research and how to build the capacity of our stakeholders to do that research using good clinical practices. So that's kind of our marching orders. So why are we such a good candidates to do this? Well, obviously, we've talked about this. We have a really unique population here. This really is God's waiting room for people living with HIV. And we had those results from our formative focus groups. It's actually been printed as a paper, thanks to Brandon and some of his graduate students. They wrote that up. It's been published. So the Coachella Valley is out there in the academic literature. And we formed this nonprofit with a commitment to doing community-based research. And some of the partners that we've partnered with here in the community are, places we know well. The Desert AIDS Project, Let's Kick AIDS Survivor Syndrome, Mizell, the center has a lot of wonderful programming. HARC, a lot of people may not know about. It's Health Assessment Research Collaboration for communities. And they do community-based research. You may have gotten surveys about LGBT health or Valley Health and things like that. They're the people that do this, and they're based right here in Palm Desert. And they're a wonderful resource, and they've been partnering with a lot of groups like DAP and the center over the years to do that kind of research. The various universities at UC Riverside, UC San Diego, UCLA, USC, people at the county, here at Eisenhower, Borrego, and there's also a for-profit clinical research group called Palm Tree Clinical that has started in recent years to do a lot of clinical research, not just in HIV, but a lot of other disease areas. So there's obviously a lot of interest in researching these issues, but we needed to build the capacity because people are in the research silos and they just don't get together the way they should. So PCORI, obviously, the whole idea was that this is going to be research done differently to meet to be patient-centered, to meet the needs of people themselves. So I'll skip over this because we want to get to the meat of it. What are we doing? So we were supposed to create a leadership structure, including all the stakeholders. I think this slide's already been up here. And there's a timeline of what we're supposed to be doing. I'll skip over that. But this is who we are. So we formed a steering committee of stakeholders from around the community and also a patient partner advisory board, kind of like a community advisory board. So this is a picture of the two groups together. And they meet every month, and they've been helping us design the focus groups of the various stakeholder communities so that from the very beginning, the questions we ask are generated by the community to ask to the community. So these wonderful people have been a wonderful resource and done a lot of work to help us get to where we are. So absolutely. Thank you all. So what have we done so far? Well, we've conducted a series of focus groups that you're just about to hear about. There's some of the flyers. There's the event today, obviously. And also we put together twice a year, we put together a newsletter for PCORI. It's part of our grant. They say you need to do this every 6 months and let your community know what we're doing. So this is on our website at har-ps.org. So take a look. It's up there, and we have another one coming out in another month or so. And we'll keep doing that on a regular basis. And once we start doing real research, of course, that'll be posted on the website as well, and public forums like this, Positive Life, and things like that. So, Brandon, do you want to come up and talk about the book? That's okay. We can go over a little bit. We have until 3 o'clock to do the Q&A. So, good time.
So I have the privilege of working with Jeff Taylor, and I don't know if everyone is here today because of Jeff, but I'm here because of Jeff, so let's give Jeff a round of applause. So I have about 5 minutes to go over some stuff that I think is important, so let me... I do? Okay, cool. So I won't rush too fast.
No.
So I want to quickly talk about our achievement to date. So we've conducted focus groups with 5 different groups of stakeholders. We have people who are living with HIV and AIDS. We have caregivers, providers, academics, and also community-based organizations. So we conducted a series of 5 focus groups with anywhere from 8 to 14 participants. And they lasted anywhere from 60 to 90 minutes. And this was a chance for people to tell us what are the health issues that you think are most important? What are the issues that kind of help you remain resilient? And what are some of the proposed research topics that you think that we should pursue? And we tried to focus on the resiliencies because a lot of times what researchers like myself focus on are the negative aspects. But we wanted to focus on the resiliencies, the things that kind of help people remain strong. So here are the question sets you can see on the board. And we asked several questions within health issues, resiliencies, and research. So these are the top hits. So the focus groups, the 5 focus groups were done separately with each group separately. And these are things that actually showed up in each focus group kind of across all 5. So everyone, patients, providers, academics, caregivers, and CBOs. For health issues, they brought up cognitive function, for example. For resiliencies, people brought up the gym. This is everyone. For research priorities, people brought up HIV and comorbidities. And these are just some of the things that came up for health issues. Other items that were brought up in the focus groups were like housing, depression, and health insurance. For resiliencies, people brought up limiting alcohol use, having pets, having an accepted community, and religion and spirituality and natural healing. And for research priorities, people brought up side effects of long-term drug use, isolation, the social determinants of health, and also medical provider education. So, to give you a few examples of salient quotes from the focus groups, we're going to start with the health issues. So, here you can see participants brought up cognitive function. And people said, it might just be a fear of cognitive memory, but memory can actually affect medical compliance. And this is pretty important. Next, we have competent care. So a participant said, if we don't feel comfortable talking with our doctors or our providers, we're not going to be able to be healthy. One participant said that they're often misgendered. Another participant said, I face stigma, and that's something that, doesn't let me be healthy. Another participant or two brought up the issue of depression, and they talked about a story of their friend who, was so depressed they couldn't take their medications. So a lot of times depression could lead to people nearly dying or obviously really dying. And then we could focus on resiliencies. So here in this quote, you can see a provider is talking about how patients are oftentimes even better educated on HIV than their provider, or they know just as much. And this knowledge keeps patients alive. Another participant brought up having good medical care. They did a few shout outs to LKA, Borrego, and the Stonewall Clinic, and feeling comfortable there and how that helps them remain resilient. And when not, stigma actually makes them feel dirty, and that's kind of negates their resiliency. Regarding support groups, they said support groups are obviously really absolutely resiliencies for people. And it could be a place where they actually trade tips on ways to stay healthy with each other. Near and dear to my heart, since I have cats, people mentioned pets. They said, having a cat really puts me on a schedule and keeps me on a routine, keeps me busy. I need to, keep track of my pets, so, I'm constantly looking out and being on a routine. Exercise. A lot of people brought up exercise. They said, dancing particularly. People are happy, there's music, you're getting up, you're kind of emboldened, you're having fun. This is something that helps people in our focus groups be resilient. And then for research priorities, people mentioned the side effects of medication. Some patients said a lot of medical professionals, they don't actually know what it's like to take these medications even though they're prescribing them. Maybe they should actually know how that feels. And then another person said, what's the price we're going to pay for, living this long and taking these drugs, and what's the long-term impact that they're going to have on our body? Maybe we should study that in research. People mentioned that we should conduct research on the social determinants of health, housing, social supports. If a provider is prescribing a medication and you're housing insecure and you have nowhere to keep it, how does that really help you? HIV and mental health. Maybe we should conduct studies on to be able to identify people's resiliencies and bring it to their attention. Maybe they have a lot of resiliencies, but they're actually not aware of it yet. And then HIV and inflammation, this is something that we did a sub-study on not long ago. And people said, what is this constant inflammation over the course of 20 to 30 years from living with HIV doing to our body? Maybe we should study this. We're on the forefront of this, and little is known about inflammation. And then finally, we talked a little bit about barriers to research, and this came up in the panel right now. So location. If I'm going to participate in a study that's in San Diego, Los Angeles, San Francisco, but I live here, how am I going to get there? And then I don't want to be in a study that would prevent me from participating in something else. So if I'm going to participate in a clinical trial, and participation means that I can't go on my normal medication, do I really want to do that? And what happens if I'm aged out? Sometimes there's an age requirement for some of these studies. So, how can I overcome those barriers? And then the next steps after these focus groups, now that we've conducted all 5 of them, we're going to be doing citizen panels to actually choose a research topic and weigh the pluses and minuses of what to do, weigh the trade-offs, and then reach a final consensus about really what to study. We're also going to be conducting research training activities locally. So maybe teaching people Research 101. What is the human subjects protection? How do we make budgets, and how do we handle subcontracts? So we're actually going to be training the various stakeholders here to do the research, and what happens when UC Riverside is gone? The research can still continue. And then at the end, we're going to be pursuing a single research topic, which has the buy-in from all these different stakeholders, people who are living with HIV, caregivers, community-based organizations, providers, and academics. So that's the goal, very patient-centered, and hopefully it doesn't have to necessarily be a single research project. It could be one behavioral, one biomedical, and we can kind of go from there. So that's it. Maybe I remained on time. Thank you.
So we'll ask the panelists to come up and sit at the table here. And now it's the chance for everybody here to ask questions and share your ideas and thoughts about what was brought up at the roundtable and the projects that we're doing here with Heart PS. So, yeah. So go ahead and take your seats, folks.
I don't think I'm up here. I think Mary's here. Oh, where's Mary?
I don't see. Right up. Yeah, go ahead and take a seat.
Did you need more chairs?
Yeah.
Come on. Don't be shy. This is not a shy group. Don't pretend that you are. Okay. Now let's get one more chair.
Yeah.
So while everybody is getting situated, does anybody have any questions? And if you have questions, we've got volunteers on either side of the audience with a microphone and hand them to you. As I said earlier, this is being recorded, so we want to make sure that you ask your question into the microphone so that it gets recorded. And if that doesn't happen for any reason, I, as the moderator, whoever the question is to, can repeat it so that the recording will capture everything on there. So I see a hand
There, and there's
going
one
up here.
down here.
Yeah.
We'll start. Jeff, where do you want to go?
Yeah, let's start there.
Lost my seat. Is there a website where a lot of this research is being recorded so that people can kind of look it up and get a little more in-depth information about it?
Yeah, are you talking about the focus groups and things we just presented? Yeah, so we just had that information transcribed and we haven't coded it yet, but we will be putting out some of the focus group information in our next newsletter that actually Eric is in charge of. So we will be putting that on paper and also online. And then hopefully we can also put the whole manuscript out to the community so you can see what people said.
Great, thanks.
I just had a question about the patient outcomes. I don't remember if it was you that was talking about the patient outcomes or the outcome studies. And is there a place where that's going to be able to be viewed by the public, where we can look at those outcomes, and how are the outcomes going to be measured? Those were the two questions I had.
Okay, I'll take a stab at that.
Okay.
So, Patient-Centered Research Outcomes Institute funds a lot of this research. So they do have a website. If you Google PCORI, P-C-O-R-I, for Patient-Centered Outcomes Research Institute, all their projects, both ongoing and then the results, should be posted there. And then your second question was?
My question was, how are the outcomes being measured?
That depends on the study. Every study is different. It's designed to ask a particular question. So it depends on if it's, clinical research, are you looking at viral load? Is it psychosocial? Are you looking at indicators of depression? Or, are they taking fewer antidepressants? That sort of thing. So it's going to depend on the study. So there's no...
So how, just my question
Yeah.
is, how are the clinics or the institutions being measured as far as effectiveness and their outcomes?
Okay. So that I think that ties into the FQHC, the Federally Qualified Healthcare Centers, and they have their own set of parameters and guidelines that they go by. So you'd have to Google that and see.
It really depends on the clinic and the study. What HARP PS is doing here is identifying the research priorities, and then there'll need to be another grant to actually do that research, and that would really be determining at that point what those outcomes would be. But if you're looking at effectiveness of a clinic, such as the Scott Hines Mental Health Clinic, we do our own evaluations and determine effectiveness of various types of therapies, for example. But that has nothing to do with what we're talking about here.
Hello. First, I'd like to express my sincere gratitude to everybody involved in this conference, the speakers and the people that have put this together, for all your years of dedicated work. Thank you. I appreciated the listing of the standout issues. However, I would like to suggest there's one big missing issue in here, and that is the issue of prisons. I'm an anthropologist. I've been doing a study of prisoners and former prisoners and of doctors working at prisons. And the HIV transmission in prisons is just really, really serious. Most people know the horrible impact of what I call the incarceration nation has been on people of color. But also there's a higher rate of incarceration for both lesbians and gay men than the general population. And the very highest percentage of people in prison today are transgender people. And so this is definitely an issue for our community. Yet the Bureau of Prisons follows policies that are extremely counterproductive. For example, they refuse to distribute condoms in prisons, even though the reality is that sexual behavior goes on. I've heard from many prisoners or ex-prisoners that when you're transferred to a different prison, and prisoners are constantly being transferred from prison to prison, they are supposed to give you an HIV test, but when you arrive, they pass around sheets of paper and they say, well, if you don't want an HIV test, you can opt out of it by signing this form. And of course, they do this in front of everybody, so the peer group obviously is pressured not to, to say, oh, yes, I don't need this form. And so then they'll sign it, and then they don't get an HIV test, and then that contributes to transmission spreads. So these are deliberate policies of the federal government, and some of the state and local governments are doing better, but the federal government is doing horrible things. And this is going on, and I think we need to pay a lot of attention to this issue. So I'd advocate for adding that to the list of standout issues. Thank you.
Thank you.
George.
Sorry. Okay.
I'll just say while we're waiting that, thank you for bringing that up. And while it didn't come up in the focus groups that we had, we would have loved to have had you on a focus group as a participant to bring that up. But yeah, there's been a lot of policies like that. And regarding the prisons, they're now publishing the names of the prisoners as they leave incarceration. So it's not the end. And also it's not the end for other federal policies like excluding LGBT issues from the White House website and excluding questions on LGBT elders from the national census, and it goes on and on.
Okay, well, he just answered the question I was going to ask about how the present administration is kind of just wiping us clean from the census and stuff like that, and how is it going to affect research dollars and ways of measuring?
So yeah, I mean, it's a huge issue, and there's a lot of resistance in the government as well, because people, bureaucrats who are working at the CDC and places like that, they realize how important it is. This is their life, right? They're not happy about this. So hopefully, some of those changes won't get implemented. I know people are deliberately dragging their feet on things like this, hoping that somebody will get impeached, or or we can just wait them out before, so we don't have to do this and completely destroy our country in the process. But in terms of NIH research dollars, because I do a lot of advocacy with NIH-funded groups, for right now they are flat funded. There's been a 20% cut, David, I think. Not yet. Increase. Go ahead.
This year, just for this year. So Trump had actually proposed a $6 billion cut, so it was like 20-some% of the NIH research budget. What I would say is that the biomedical side of the NIH is a huge moneymaker for pharma, and so conservative Congress people like the NIH, and they put $2 billion back in the cuts last year and added $3 billion this year. So for the first time, I think in almost a decade, there's actually a significant increase. I don't know how long that will last. It's hard to say. What I would say is I was someone who worked in HIV prevention during George W.'s time, and the organization I worked for, the Stop AIDS Project in San Francisco, was the target of a particular conservative congressperson staffer, and ultimately was successful at getting us defunded by the CDC. What I would say is that during that time, researchers got very, very smart about erasing words from the titles of their grant proposals, because when there were audits by Congress, those are the things that got flagged and people potentially got defunded. Fortunately, there are enough veterans left in those areas that they know how to do that now. That's fucked up that they have to. But at least we've been through it before. So what I would say is, at least for now, maybe we're not in quite as much trouble as we would have been if this hit us blind. But still, it's scary. And if for the CDC, oh my God, I don't know. That's, yeah, we'll see.
And quickly to mention that PCORI is actually funded by the Affordable Care Act through Obamacare. So hopefully this funding kind of remains as we build upon what we're doing.
Yeah, they've tried and tried. I don't know how many votes there have been in Congress to defund Obamacare, and it hasn't happened. I think people like their health care. It's just like Social Security has become the third rail of American politics. So hopefully that will protect us in the short term. But, with the implications of the tax law, across the board, there's going to be such decreased revenue, who knows how that's going to affect future funding.
Also, one thing, this is an amazing turnout today of like over 250 people, which is absolutely terrific. And that is the reason that HARP exists, because of this population here. There are so many people in Coachella Valley living with HIV and more people moving here. One easy thing, I think, for everyone to do today is go to the HARP harp-ps.org website and get a friend to register and give us their name for future research and to find out more about this. So this can grow and grow and grow. We can have more people participating in research. So many people who are willing to and want to be part of this research, which is really great. So let's keep it going and let's keep it growing. And one easy thing to do is just go get a friend to sign up and be a great thing.
Anything from the panelists you want to?
I'm just curious in what ways HARP is joining up with similar organizations from other countries like England or Canada or Mexico City. You know, a lot of those countries with major populations, they have the same aging community. It may not be as concentrated a petri dish, but they still have that same issue that they have to struggle with. And Canada, of course, has a lot of socialized progress above us, obviously. And England is very progressive in its own ways. I'm wondering, are you teaming up to join up on the research level to figure that out together?
So internationally, there are conferences like CROI, the Conference on Retroviruses and Opportunistic Infections, which is a major international conference that happened last month. We're doing an update on that next month for Positive Life, actually next week, next Tuesday. And a lot of us, David and I, do a lot of biomedical research advocacy, and we do have colleagues in Europe. There's a European Community Advisory Board. They've already had a special meeting on this, and we had a representative from the U.S. go to that, and we're talking about ways to get together with other community activists at the World AIDS Conference in Amsterdam coming up this summer. So we're starting to think about it. I mean, this is all very much in the formative stages. I think it's kind of caught everybody off guard, even in developed countries like Western Europe and the U.S., that we need to wake up and start doing something about this. And we're also thinking about, this isn't just in the developed world, but in resource-limited settings like South Africa, Thailand, and South America, and places like Brazil and Peru. They've been doing research there for decades. And a lot of them have the research infrastructure to do this, and they have large populations living with HIV who are fortunately growing older. So we're thinking about it. We don't have any formal connections, but it's very much on our radar. And whenever we talk to people from other countries, we ask them, "What are you doing on the ground? What's working? And how can we partner?" One example that I'll kind of put out there that's getting traction is UCSD has a really unique study for cure research called the Last Gift Project. And one of the challenges in HIV cure research is there's this reservoir, we talk about this is why when you stop your meds, the virus comes back. It's hiding in different parts of your body. And how do you measure that? You go to your doctor, you get a blood test. Well, HIV is not just in your blood, it's in your brain, it's in your lymph nodes, it's in your gut, organs all over the body. And obviously you can't test those very easily. So what they've decided to do is find people living with HIV who are terminally ill from something else, cancer, Lou Gehrig's disease, something like that, who are dying. And what they do is they enroll them in a study and start sampling their blood and say, when you died, you agreed to donate your body so we can test these organs. And they do a rapid autopsy. For years they've been doing autopsy studies, but they wait too long, and the samples aren't good enough to really tell them what they need to know. So this is something that started at UCSD. They've enrolled, I think, 5 or 6 patients already, and there's intense interest from all over the world. And so they've been meeting with people in Geneva and other places in Europe. And so we're hoping that this kind of research and interest, will be global. So, once we start doing the research and start reporting the results at these conferences, other people hear about it, both researchers and community activists, and that's how it grows. That's how it happened with good treatment, why we have good treatments, and that's what we need to do with aging research. Right in front of you.
Liv, thank you for asking that question. And also it's just like a fast comment. There's a lot of interest around the world, but curiously, it's also a lot of not wanting to do certain things. Even in the last international conference, there was like 0 things happening about growing older with HIV. In this international conference,
The design for the logo of the international conference, it was only for people between 10 and 30 years old. So there was a lot of fighting precisely with these people because how is it possible that this is happening? So even if there is a lot of interest, there's still a lot of ageism, remember, not only here but in many parts around the world, sadly.
Don't be shy.
Just a second. Did you guys talk about the Denver principles earlier?
No.
Wahida alluded to them, I think.
Yeah.
Did you talk at all about it? Can you say a little bit about what it is, and did we come up with anything at the round table?
No,
Just to. Okay.
It was mentioned, Greg. I mean, for those
Let's
of
first
you.
start with what are the Denver
I'm
principles?
sorry. So the Denver Principles were an amazing group of people at that point. I mean, it was 1983, who had been diagnosed with AIDS. I mean, we didn't even have a note for sure it was a virus. It was about a certain level of empowerment, that said, we are not victims. We are not, what's that? Patients. We are people living with HIV. So, and there were a number of other points in the Denver Principles, other principles that grew out of that, being empowered to make decisions, healthcare and other kinds of decisions, and to be directly involved in deciding what happened with bodies and through research and all of those kinds of things. And I think they formed a backbone. But I do also want to say it's really important to not forget that also came out of the civil rights movement. It came out of the women's rights movement, so it didn't spring out of nowhere. So I think it's always important to acknowledge where those things came from. But I think, but what there is a recognition is there does need to be maybe a Denver Principles 2.0 of sorts to acknowledge the realities of where we are in the epidemic. And so that is not something that was explicitly said, oh, go do this out of the policy roundtable, but it's not a bad suggestion. So
my question, and maybe you guys said do some traveling and going around to different cities. I find that in some organizations now that, like you said, it came out of the civil rights movement, nothing for us, about us, without us. So always having a place at the table, always the people from a community making the decisions about anything that's going to be decided for them, that they have a place at the table. And I find that that HIV even more so has become AIDS Inc. And more at different organizations there are that may be led completely by HIV negative heterosexual people. And I find it really, really, really populated in some agencies in San Francisco. And I think it's really curious that there isn't that value placed and that there hasn't been a voice that's saying, like, we want it to be transparent. Are there out HIV positive people in leadership at your organization? Are they on staff? Are they on the board? Are they in the community advisory boards? Like, are they there, and do we have a place at the table? And I'm just curious to know, do you guys have any feedback on that? Do you know, is there any study around that? Is there transparency in agencies that's saying this is, because we're more and more conscious of having diversity around marginalized communities, of trans people and people of color and women, and trying to be more. And I think that it's really interesting that people themselves as HIV positive people are not being represented. There isn't. Go ahead.
One thing I was going to say is that one of the things that's so unique about this study that we're doing with HARP-PS is that the PCORI grants are very specifically about the stakeholders being involved from the ground up. We're not even creating the research questions without the focus groups, without the community input. All of that is from the ground up is focused on exactly what you're talking about.
And I think there are opportunities for that are really ripe targets for activism. One of those is, the executive directors are hired by the boards of directors. And if there are no openly HIV positive people on the boards of directors, they won't push to hire openly HIV positive people as executive directors and to ensure that they're in leadership positions in the organizations. And I think that's really critical. But I think also there needs to be the support of funders for that kind of stuff too, and to really hold organizations accountable for that kind of community inclusiveness and supportiveness. But then the other part of it in terms of the research community, just insisting that, I mean, you guys have done an amazing job of this, but ensuring that someone who is openly positive and from the community is a principal investigator on the study, and those kinds of things make a huge difference. And you have the power to insist that that happen in many cases. And so, but what I would say is that's not easy. It takes work, it takes commitment. Being on a board of directors, that's not easy. But one of the things I would say, even at my own organization, this is not, when we got started in the mid 80s, all the way up until the late 90s, the average donation to my organization was $35. And we were able to survive on that because we had enough people who could give us $35. We don't have that anymore. And so for our board, they have to bring in $10,000 to $15,000 apiece. Now, that doesn't mean that they personally need to write the check, but they need to find someone who will. And that's a big ask, especially to be totally representative in the community. Because I don't know about you, but I don't have a lot of friends who can write a $15,000 check. So anyway, those are just a couple of points.
Are there models, David, for bringing in people from communities that need to have a place at the table without? There must be models for bringing on people that represent without being that type of board member, without having to be writing a check.
The one thing I would say is yes. The second thing I would say, though, that's a problem with any kind of inclusiveness and diversity is, do you want to have to be that angry person at the table that is insisting on something? And too often, if you are the community representative of any kind of process, you end up having to be that angry person that ends up getting thrown out because you're the crazy one, that's always asking for too much, So that's the other part of it, is helping to support each other to be that angry person, to demand what's right. So, and there are models for that. There are.
There are models for it, and there are also models of it failing.
Yeah.
Unfortunately. And so perhaps a compromise position can become useful where you have the angry people and they're visibly angry and they take the flak. And then there are others who perhaps have the same set of beliefs and are working for the same goals, but can say it in the way that the existing board is willing to hear.
Good cop, bad cop.
Yeah. Yes.
But yeah, to that point, historically, I think there's a reason this happened, and part of it is we're the victims of our own success. We were able to convince the government and funders that there's a need and we need more and more money. With more and more money came more accountability, which meant, you've got to hire an accountant, you have to do this. Next thing you know, you've got MBAs as CEOs of nonprofit organizations. So it's really incumbent upon us as the community to keep them transparent and hold their feet to the fire and say, we do need that seat at the table. Yes, there's a lot of money at stake, but this is who it's for and what it's for. We can't forget that.
Can I just add something quickly? Hi, my name is Barb Cardell. I am the vice chair of the U.S. People Living with HIV Caucus, and we do a lot around trying to ensure that people living with HIV are part of the conversations. AIDS United has a grant called the Positive Organizing Project, which has for 5 years partnered with groups and provide coaching for people living with HIV to develop more leaders living with HIV. And I think that there are examples where there have been people living with HIV on boards who have been angry and have been frustrated. And what we have discovered is that you need to set people up for success. You need to have partners on the board. And at the board for my own AIDS service organization that I'm a client of, we actually have it in our bylaws that there must be people living with HIV on the board who are openly living with HIV. And that's been in our bylaws since 1986. voice. And they always say, well, we can't, with the give or the get, and how do we include people? And what we do is we go out to the community and we say, we have people living with HIV who need to be on the board, and they need to be sponsored. And how will you do that? And so, I think we have to continue to think really creatively around how we are at the table and to hold ourselves responsible, so that if somebody wants to be on a board, I can train them about how to ensure that our voices are on the agenda and that our messages are being carried, so that I don't have to be on the board, because I'm tired of being on boards. I'm serious, right? I mean, many of us here have done this work for a really long time, and so the challenge continues to be, how do we help find those people? And they don't have to be young. They can be people who are retiring, who we are then going to help support to become board members, to hear the voices of the community and to participate. And the other thing about the Denver Principles, so I'm not sure if people know, but I'm from Colorado. And so I take the Denver Principles very personally. I love them. I look at them and I say, where am I in those? Really literally, they do need to be revised, refreshed, whatever we're going to use the language for. And the caucus, as well as the Reunion Project and a number of other groups, are actually talking about looking at it this year, because it's the 35th anniversary. They were great in 1983. They are still great and powerful, but we need to make sure that it talks about our trans sisters and brothers, that it talks about people of color, that it talks about women, that it talks about aging, that it talks about so many of these things, that when we look at the revised Denver Principles, or as we might call them, Principles for Us All, that it talks about people who have supported us, our allies who have helped us get here, our doctors, our researchers, our family. So when we talk about long-term survivors, we're talking about all of us. And really, ultimately, when we come to look at that, I hope that that will be included in the Denver Principles. But if people are interested in partnering, please come and find me, because it is exciting work, and it's daunting, because it does hark back to the women's movement and to the civil rights movement and to the labor movement and social justice movements, and that's where we're coming back to, is how do we continue to ensure that all of us are represented in documents that are supposed to be about us, because literally nothing about us without us, because this is a perfect example of what power happens when we are there at the table. So thank you.
Yes, is there a question? No. We have another half hour. We don't have to use it all, but if you have questions, please.
I would just pose a question to everybody on HARP PS. Do you think there's enough activism in the Coachella Valley? And if not, what do we need to be doing?
Please identify yourselves. I volunteer with Let's Kick Ass Palm Springs, and one of the committees that we would like to be forming is, in fact, an education and advocacy committee. So, if you're interested, here's your invitation. Please go to our table, pick up one of our handbills, contact me. We like to work with as many agencies as we can, the Center, DAP, Eisenhower, and yes.
Okay. And I guess the second part of that question is, maybe I shouldn't identify myself. I see a lot of fundraising where I work. I work at the convention center, and I see a lot of good being done, but I don't think it's enough.
Excuse me.
The fundraising that's done is
fantastic.
I mean, they raised $3 million at Steve Chase this year in one night. So
right.
There's a lot of wealthy people here, but I think that people sitting in this room can help as well. So,
well, as Dave indicated, I mean, tiny donations, they can really add up. And when you get more and more people, I mean, this was one of the exciting things in the Palm Springs City Council race last fall, was lots and lots of small supporters behind one of the candidates put her neck and neck with a candidate who had the big financial backing. This is how Barack Obama became president. You know, it was people like me giving him $5 every month. So yeah, small donations on a regular basis they're fantastic. From that, we can build budgets, and we can then present what we have and what we're doing with what we have to people who can write larger checks, and then push forward for more advocacy.
Thank you.
Yes,
yeah, to that
David.
point, foundations and government grantors love it when they have that kind of broad-based community support, and that's when they start opening up their checkbooks and giving more. So it does make a difference.
Just on this topic, there in San Francisco, there was an organization called AIDS Emergency Fund, and they used to have penny jars in every bar, and it's a penny at a time, but they're no longer in existence, but they raised so much money that way. So in a city like Palm Springs, where there's just all kinds of places where you could do even something as little as that, I think it would help.
And the AIDS Emergency Fund raised more than money. Because it was so small and because they were right there at every cash register in town, you felt good about it. It's like, I've got 15 cents, in it goes. And so everybody in San Francisco knew about them. Everybody contributed. It really pulled the community together around that idea, the idea of community participation, because that is how it happens. It's not just a few noisy people.
Yeah, you have to get everyone invested. We have a question over here and then down here.
We've been talking now about ASOs. In Palm Springs we have a very large ASO. And then if you bring up fundraising, the $3 million is great on one night, but then that money is going into a place where none of us in this room or any of the long-term survivors are deciding where that money might be going. Maybe we go to the county and get some county spending decided upon, but with DAP funds, we have no idea where they're spending it, and now they just are announcing $20 million worth of new buildings and services. And then you get to the point where the executive director is making really several hundred thousands of dollars, and anytime you say you want to hold them accountable, but in the past when we've tried, there's no sooner place in the world than Desert AIDS Project to be that troublemaker and immediately find yourself walk to the door. And some of the times you're very people that'll, like take the wind out of your sails is when these $1 million donors will get into a conversation with you and tell you right to your face what beautiful work this ASO does for the people that have AIDS, but you're sitting there as a person that has AIDS and you haven't had one thing done for you from this organization. So I'm not to say that I'm against the donors. No, we love the donors, but it's really hard to be an activist when you're going against such an institution, and I find it even hard to say bad things about them. But I really want to, especially the salary issue, because I just don't feel like one individual should be making. We did the AIDS walk here in Palm Springs. We raised, I think, about $350,000. That maybe covers his salary. I don't think so. So you put it in those terms, I don't know. That's all I want to say right now. I'm kind of upset about that.
Yeah, there's not a lot you can say to that. I think we need to keep, holding people's feet to the fire. And the other thing we can do is if we see needs that aren't being met, and this is why we started HARP PS, just go out and do it. And we find that once we do, suddenly DAP wants to participate because the community has gotten together and said, this is a priority, this is a need, and we're going to start addressing it. And then everybody starts coming to the table. So I think that's how you build the coalitions and the recognition of the needs and start working together. So, we don't always have to be kind of tilting at windmills, so to speak, but, be the change you want to see. So that's one way to do it. It's not a perfect answer, and there are no perfect answers, but that's one.
Well, as the HARP board member who's currently wearing the fundraising hat, I really, really appreciate you guys talking about community funding and examples like San Francisco, because we're really looking for those little things. And one of the little things that's not on our website yet, but will be momentarily, if you buy anything from Amazon, designate us as your charity. I've designated us as my charity, and in the last year, I've given $29 to HARP. not giving money to HARP besides the $29, granted. But, that's a little bit from everybody who buys from Amazon in this valley, and that will add up tremendously. And there'll be a link on our website to take you to the right place in the Amazon website where you can, whatever. But really, thank you for those suggestions.
And a little more on donations. The large donations tend to be earmarked. They're specified. They're like a grant, and certain things have to happen. And so the donors are approached with an idea. We would like to do this. And then they give money for that specific idea that, that they've been convinced is worth supporting. And this is why it's important for HIV positive people living with AIDS, to be on boards and have a representative voice there. Understand that all of these organizations believe that they're working for us. And so they see themselves as friends to the community. And so you kind of have to work with that. It's not perfect, but or at least, it seems to be one way. I'm not sure that directly attacking them works really well at this point. That was very effective in the late 80s. Now these organizations are there. I'm not sure. If we think of them as friends and try to approach them that way, then perhaps we can get money apportioned differently. But it's really about cultivating the donors and for the large donations, and getting them to believe that the concerns voiced by little people are as important as the concerns identified by a leader of an organization.
So then we see in the press that the large donation is specifically for the such and such new clinic that 5 years later never becomes fruition. And so, we're not stupid. We're long-term survivors. We've seen it all. And by now we get when there's a giant.
Well, the money is actually, since you're talking specifically about DAP, that $20 million drive is in fact to produce housing. It will more than double their current, affordable housing, and it doubles the volume of the clinic capacities. Well, she's part of what's going on. This is, there actually is stuff going on there, and it's continuing to develop. I'm not their spokesperson. I'm just that all.
So one of the things I'd like to address the organization that you were talking about, and one of the things you did talk about a little bit is coalition building and working with partners and so forth. And this isn't really a fundraising question, but we do have a lot of AIDS assistance programs here in the Valley. And I'll be a disclosure. I sort of helped the center get off the ground and do things with them.
Enormously grateful, David.
What?
I'm enormously grateful for you.
But one of the concerns I have is that there are so many out asking for funding, and you're asking for funding. And how can, what I really see is that everybody is trying to find a niche, whatever that niche might be. And I also, as someone who isn't HIV positive, but has watched this for a long period of time, get real concerned that we build institutions based on HIV, and those institutions become more powerful and bigger than the issues that they started out with, because it's very difficult to give up power. And so I guess one of the things I'd like to have you look at, and maybe you did, is how can we get these groups without starting another group, to listen to the needs, whatever those might be. And yes, I also hear a lot of people saying, well, there's a food bank here and there's this here, and those poor people, they just need our help. And that's true, but that's putting those people down, sort of, in a way, as though they can't survive on their own without our help. And it's a difficult question, but I would like to see this organization, if you are looking at community things, to figure out a way to bring some of those groups to the table. Do we need 3, AIDS assistance programs? Do we need all of these things? Or is there a way to somebody say, well, it's time to either merge, close down, or find another way? But I don't know the answers, but it's certainly something that I find troubling, because I certainly want to financially help someone, but I also feel like I don't need to go to every fundraiser and wear my fancy jacket.
Right. I would say that an organization like HARP has the potential to do some of what you're talking about, if I am understanding you right, because there are people from all different agencies. Yeah.
Right.
And so there's so many of us
naturally.
present. And what I said earlier about Let's Kick Ass wanting to work with everybody, I think you're absolutely right. And there are people working to make this happen, to knit together programs so that the community can benefit, because yes, it's a hassle to be constantly dinged every time you go out the door for another 5 cents.
I think one of the things about the HARP-PS is that because this is a Macquarie grant-funded project, it is starting from the ground level, looking at all the different stakeholders. It's a massive coalition of people from all walks of life. And part of the community, all of you, everyone here, is going to have input into what we finally, ultimately decide will be the research priorities. And so then at that point, we then look, for future funding, to look at the research priorities that are really for and about the people they're serving. And so that's really what HARP-PS is all about.
And it's a long-range plan, but yes.
And one of the issues you talk about, it's not so much research, it's more community advocacy. Where do funds get allocated throughout the entire community, not just for research. And one of the things that we've discovered in the course of doing these focus groups and working with groups like Let's Kick Ass is that what we need is a kind of regional coalition on HIV and aging. A few years back, DAP tried to start one and it kind of fizzled, but I think we're now at the point where everybody recognizes that this is a huge need and no one organization can address this. And we need to bring everyone to the table to discuss these policy and funding issues, not just research. We can do research, and we're on our way to getting there, and that'll happen. But I think these other issues that the community needs to get together and bring them all to the table. And so hopefully that's something that can happen. We can't do it alone as an agency, but I think if we can get everyone to the table and say, we need to address issues like homelessness and housing and things like that for people with HIV, we can make that happen.
And I wonder at some point if we don't involve the city government. We have a very receptive and community involved city council at this time. And so some of us are hopeful that Palm Springs can help, with the help of the city council, we might be able to expand and improve the usefulness of some of the coalitions that are just building now, just starting.
Yeah, that happens in a lot of bigger cities. It's a smaller city like Palm Springs. We don't have a public department of health and things like that.
Right.
So, but the county provides those services, and Ryan White funds are overseen by the Ryan White Planning Council. And that is a body that is specifically for people living with HIV. They call them HIV consumers. And they have seats on that. And they meet at least every quarter. And so I encourage you, if you're interested in these issues, talk to them, because they fund DAP. They fund a lot of the HIV services throughout the county and here in the Valley. And that's one place where there's specifically a structure designed for people living with HIV to have input on how those monies get allocated. And they need to be reallocated. One of the things that's happened in recent years is with the rollout of the Obamacare, a lot of the money was being spent on direct medical care, and now we have insurance coverage for that. So fortunately, knock on whatever this is, those monies won't be cut, and so we can reallocate them to other needs that have been neglected for far too long. And that's where community advocacy needs to come into play. So if you're interested in those issues, definitely look into it. And I have those contacts if you're interested.
Hi, Jax Kelly. Thank you so much for this entire day. I mean, this has been amazing, and I've been very enlightened by all the feedback that's been even presented here today, especially from people who really have strong opinions about where the direction of our healthcare is going. And I don't know if you're doing that today here, but I would strongly encourage you to take names here. I mean, if people here are in this audience who want to participate in some of the things that HARP is working on, including these focus groups, which are still continuing, please give them your name and your contact information.
Yes, thanks, Jax. Go to the tables, write your name down, send us emails.
Yeah, one thing Brandon I think alluded to is after these focus groups, the next step is to do a series of citizen panels to kind of discuss those results, kind of like we've done here today, but in a more targeted fashion, making sure that we have 5 people from each of those 5 stakeholder groups. So we need more bodies representing people living with HIV, community-based organizations, things like that. So please do sign up and then follow up and say, what your interests are, what your background is, and how you can contribute, because we're going to need more help going forward.
Jeff, I have a burning question for Mary here. So Mary, like Jill and Eric, is part of our steering committee that kind of built the questions that we asked in the focus groups regarding health issues, resiliencies, and research topics. And now that we've kind of shown some of the results today, what do you think about those, and were those what you might have expected, or are there things that you kind of wanted to see that weren't there, or what's your take on the focus group results?
My take on the focus group results is there was very little input from women, and doing small things consistently creates major change, and we just all have to participate.
Thank you.
Thank you.
Yeah. And one of the follow-up things we're going to do in addition to the citizens panels is we recognize that it's really hard to get, marginalized communities. And although women are half of the population in Palm Springs, they really are a minority, given our unique local demographics. But we are going to have a specific focus group with women. We're going to do one with the deaf population and one with the trans population, so we can really get at the issues that these marginalized communities are experiencing.
I think in the prisoner population really needs to be examined.
Thank you.
And
Was it
studied.
question here?
I do want to thank you for all of your work and your dedication over the years, for all the people on the panels and so forth. But right now, I just want to express the fact that I'm sort of in a mind fuck right now, because I appreciate your advocacies. A question that has surfaced for me is the fact that should I, or am I willing to involve myself a little bit more in the advocacy part? Because I've spent decades looking at myself in the mirror every day, asking the question, when am I going to get sick? And now I've reached a point in my life, after many workshops and many support groups and stuff, deep down inside, I just want to get on with my life. Because I'm tired of battling the stigma, listening to people's cruel jokes and so forth, and also denigrating myself for having HIV. So that's my mind fuck at this moment.
I think you make a really good point. I mean, something that came up in the roundtable is that social connection is its own form of advocacy, and it's its own form of community building. And given that social isolation and stigma and all of these, I mean, that was another huge one, stigma and everything. If there's a way that we can overcome stigma, really work on social connection, all of those kinds of things, that is advocacy, because it's building connections. And it's not just writing a check. It's not going out on a march. It's not, signing a petition. Those kinds of things. I mean, I would just say at Project Inform, we had the hotline, and they got all the credit because they would answer the calls and all that kind of stuff. We also had this long table in the middle of the office where we had the most dedicated group of volunteers who came every single day and stuffed envelopes, because everything was in paper. Remember, we sent out the newsletters and all that kind of stuff. And you know what? They were the life and heart of our organization, because they were there. They were there every day. They talked to everybody, and sometimes they devalued the part they played, but it was absolutely critical. And I don't think there's too small of a role anyone can play in this. So I want to emphasize that.
And I want to just piggyback on that, because I think it's also really important to realize that it's healing and therapeutic. Mm-hmm. And that's when I put on my little psychologist hat here and say that, along with the advocacy that everybody does what they can in whatever world, in whatever place they can, that's advocacy, but it's also really healing to have those social connections and to do whatever you can in that moment to connect with someone else. And that's how you take care of yourself as well.
Thank you. That's one last question.
If you want to know the budget of any not-for-profit, there's a number of websites. GuideStar is one of them. Look at their tax. They have to do annual tax returns. You will find out I think the 5 largest salaries amongst the organization. You'll find out their income, their expenses. Sometimes they're really complicated because they're really big, and sometimes they're really easy. But you can also look up their biggest benefits, how much they spend on a gala, how much they get in, and you'll be very surprised at how amazingly well-run certain groups are and how amazingly terrible they are. But the thing that people don't do is they don't look at that, and that's, I think, a very, very big indicator of the kind of organization you might want to support is one that is fiscally responsible.
Thank you. We have time for one last question, and then we need to get to our 3 o'clock session. So, Bridget?
It's less of a question and more of a comment to your point, and not to negate your frustration with DAP. I understand it. It's not the first time I've heard it. However, being a nurse working at DAP, being a person living with HIV, being a person who takes care of people living with HIV every day, there are a lot of good people that work at DAP. There are a lot of good people that want to do the work, that enjoy the work, and that live for the work. And that's part of the reason that I'm excited to be a part of this process, because it involves community, it builds community, it gives a chance for, in this forum right now, for people to express their opinions and their ideas and their feelings and what they've survived and what they've gone through. I'm not technically a long-term survivor. I've only been positive for 5 years, but I still identify on some level with everyone in this room, which is, I got to that point through DAP. So it has its issues, it has its concerns, but I couldn't let it slide by without saying it also has some really amazing people working there.
And thank you, Bridget, for being one of those people at being part of PARC. This has been terrific. Thank you all. It's almost 3 o'clock. So, Greg will say one thing, but I just want to let people know that the sessions are starting at 3. And those will end at 3:50. 4 o'clock, reconvene back here for Cleve Jones' keynote speech. And one other thing.
I just wanted to say, anyone that was interested in participating further in our citizen panels and our continued focus groups, please see me, and I'll give you my business card, and you can drop me an email, and we can get you signed up.
Right,
Thank you.
And Greg.
I just wanted to respond to the gentleman that said what you were feeling in the mindfuck, and I just want to echo what everyone said, that we all know this feeling of being incredibly fried and just feeling this incredible fatigue of living this life as an HIV positive person. And I just want to say that some people take a break from their activism. Some people take a break from their volunteerism. There's so many ways of being social, and I just wanted to say that there's a retreat up in Northern California that I do that is for people that are long-term survivors and their loved ones and other people that are HIV positive. You're welcome too, nurse. To say that we come together and deal with all that, the years of stigma, the years of loss, just all that pain and suffering, and it's an amazing opportunity of getting that support and kind of looking at some of that stuff that some of us never got to do. We just never got to honor what it is that we've walked through. And so I would like to talk with you afterwards, but I just want to say, and thank you everybody for your work. It's always wonderful. And I want to say, Palm Springs is so lucky. You are so lucky, the people that you have and the way that you come together from the ground up. You guys, you always do it. It's incredible. Really great community. Congratulations.
Thanks, Greg. And one last thing, there is, people have heard of the Life Group LA. Sunny Rose from LA comes out, she's coming out next weekend. So Google it. It's been in the DAPCAN newsletter. Ask us, we can get the information to you. But she does a similar weekend-long retreat for HIV survivors, and it's a wonderful experience if you haven't done it before. And it's not exactly like what Greg does, but very similar. And it's a really healing, wonderful experience. So if you're interested, check your DAPCAN newsletter or talk to one of us, and we can get you the information.
And it's free.
Yeah. Best things in life are free. So thank you again. Go to your last session, get educated, and then we'll come meet back here at 4 o'clock. Oh. Okay.
Great job.